Hi, everybody. I hope that you are doing well. We are moving right along with the term, and we are now getting into week number 3. So in getting into this week and discussing some of the elements of culture and health and science, I'd like to share some slides, some information, and also help you to feel prepared as you gear up for completing the annotated bibliography. So as we get started, we'll talk a little bit about the annotated bibliography, we'll discuss culture, and we'll discuss some of the ways to support diversity in the context of healthcare. To get started, I've received a couple questions about the annotated bibliography. So this is your weekly assignment due on Sunday. So you have a quiz, but you don't have any sort of Canvas discussion for this week. Instead, I'm asking that you complete and turn in that annotated bibliography assignment. So the annotated bibliography is not meant to be a formal essay with an introduction, body paragraphs, and a conclusion. You should think about this assignment as essentially allowing space for 5 to 7 formal citations in APA, MLA, or Chicago format, and then a paragraph explaining some of the key ideas and ways that that article is connecting to a topic of your choosing. So while you'll be doing essays that involve creating independent work later on in the term, this is instead an opportunity for you to do some research and look into topics that interest you. On the front page of Canvas, I have an example of an annotation. So your annotated bibliography is just 5 to 7 annotations that look just like that one. So in this one, you might consider a variety of questions as you're figuring out a topic that you're really interested in exploring. First of all, what is it that got you interested in this course? Perhaps you're a health and human performance major. Perhaps you're interested in occupational therapy. What do you see as a trajectory after EOU? Or perhaps, if you're already working and professionally involved with a group or organization, like you work up at the hospital, what is it that you do or that you're interested in exploring further? Perhaps you're really interested in how we communicate about health to children and pediatrics. Maybe you're interested in communicating about pain and managing and coordinating care in that area. Health communication is a very big field. There is a lot of communication research that's been done here that relate to a whole bunch of different topics. To give you some examples from what I do, how is disability advocacy and health communication intertwined? How can folks with disabilities advocate on issues? So that's an example of a type of question that I might explore for an annotated bibliography. Maybe there's a topic or issue that has stood out to you in this course. Maybe you're really interested in how to break down barriers in patient-provider communication, or maybe in our discussion this week, you see that the issue of culture is really important and one that you're interested in exploring further. And what is something you want to learn more about? Maybe there was something that got your attention as we were talking in class. Maybe you're really interested in media and how media portrays illness and aging. So that's an area that's always fair game too. I encourage you to start with a specific idea. You're always welcome to zoom out if you're doing some searches like on Google Scholar or JSTOR, and you're just not finding the sources that you need. And if you're hitting a wall or you're trying to decide between a few different ideas, or you're having difficulty with finding sources, please reach out to me through email, through office hours, and I'm happy to talk with you and help you to hone that idea down. Think about the annotated bibliography as a starting point for some of the work that you'll be able to do later in the course, but not something that binds you to a particular topic if you decide to go in a different direction for later. I look forward to seeing the work that you put together. So this week, in getting into issues of diversity and culture, there's a variety of reasons that these issues are incredibly important. I would provide a historical example here with regard to hysteria. You might be familiar with, in the past, the way that hysteria was used as a catch-all term to describe a range of physical, mental, and social challenges or illnesses that faced populations, particularly women. It was especially common in the past for a variety of different health concerns and issues, many of which might be related to mental health, many of which might be diagnoses of particular conditions, to just be couched under a broad term of hysteria, right? Referring to someone as hysterical and suggesting that something as simple as a massage was the solution to that issue. As we know, this is an incredibly sexist and problematic way of understanding health and understanding the variety of health challenges and experiences that impact women. For instance, a lot of health conditions, women are disproportionately underdiagnosed and as a result have greater difficulty of receiving care and support. So the cultural understanding of hysteria as a catch-all term was one that had disastrous consequences for the health, the well-being, and support of women over time. People who offer similarities in terms of their background and lived experiences tend to better understand each other, particularly when it comes to advocating on issues related to health and science. This is why offering a team of diverse health experts is important. People are more likely to acquire and build trust if they see people of similar backgrounds to them being represented in the healthcare system. Stereotypes and bias, of course, play a role as well. As mentioned, the stereotype that someone is being hysterical was used in a way that denied many of the forms of specific care that people needed. And lastly, some of the challenges of historical marginalization in the healthcare system can have significant barriers to health access. We might think about class and the cost of healthcare and many of the ways that a lot of health support are financially unsustainable. We might also talk about some of the ways in which populations have oftentimes been not able to receive the same quality of care, such as the role of segregation in health outcomes. So marginalization and being left out of the healthcare system is something that many experience and is a challenge that requires us to be supportive of the diverse experiences of individuals seeking out care and seeking support. This relates to the idea of ethnocentrism. You might be familiar with this idea referring to someone who believes that their own culture and set of values is more correct or better than those of others. As human beings, we oftentimes are drawn to what's familiar to us, what makes sense, what fits in the sense of our own experiences, and that means we're more likely to attribute value to that and see that as the best option. The way that I think about care, what I think it means to be healthy is the best way to go, is oftentimes a starting point that people have. But this might mean that we leap to conclusions. We stereotype and we make assumptions about others based on the limited information that we have. For example, rushing to identify behaviors in other people, assuming that, for instance, the reason that someone is diabetic is a result of choice rather than the result of genetics or issues as it relates to social and economic disparities. So ethnocentrism is an impediment to care because it leads us to make conclusions that are not necessarily accurate of a patient's lived experience. As mentioned, socioeconomic status covers a lot of different areas. It can be the income, education, employment level that somebody has experienced. Of course, in the context of inflation and changes to the job market over the last several years, we've seen a lot of issues as they've come up related to socioeconomic status. If somebody is of lower socioeconomic status, it's perhaps unsurprising to note that they are less likely to have positive experiences in healthcare. They're not receiving as much support. They are not able to receive the best quality of care, and as a result, are experiencing, far more negative encounters. And this can cause a feedback loop where people of lower socioeconomic status are less likely to reach out and seek support because the experiences that they have when they are able to afford it are not good. So one issue related to this is health information. Those of lower socioeconomic status oftentimes have greater difficulty engaging with health information. It isn't that people aren't intelligent or not able to understand material. It's that they haven't been in that world to the same degree. Someone is given a brochure, they're described a set of possible symptoms or issues that could make someone more likely to catch a particular condition. And that information has just not been accessible, available, or part of one's life to incorporate in that regard. One good example of this is to think about food and access to food. Oftentimes, access to things such as healthy food, fruits and vegetables, are not always available for someone to easily purchase from a store, depending upon where somebody lives. So health literacy is an important element here. It is the skills that are deciding the motivation and ability of people to gain, understand, and use information in support of good health. In other words, health literacy is not just understanding, but knowing how to apply and use material. I understand what goes into a healthy meal and what I need to get in my daily food intake. So I'm going to make choices that support that every day. Health literacy requires a variety of things. You have to know, of course, the language that's being communicated, which can be challenging for people for whom English is not a first language. Access to information. How do I get this? We can't assume that internet is widely available to everyone, even though it's definitely become more accessible. Somebody interested, right? Do they care about their health, or do they see a particular action as a linking to a particular outcome? Social skills are needed too, the ability to reach out, to ask questions, seek information. Hearing and vision, the ability to sensorily process and understand the information as it's being given. How to apply information, right? So I understand how to cook a basic dish, okay. How do I use this in terms of maintaining my own health? And being able to put that information into practice is crucial. If somebody has less health literacy on a particular issue, they might feel like raising their hand and raising a question is asking a bad question. They might be less willing to engage in the topic and seek out that information because they're worried that in doing so, it will make them seem stupid. So making an environment that's comfortable, that's supportive, and that allows people who might not come in with the same level of knowledge on the topic is crucial to establish good health literacy. One model that can be used to help in health literacy is the Ask Me 3 model. What is the problem? What do I need to do? And why is it important to do this? If people have a good understanding of all three of those things, they're much more likely to pursue health outcomes that are supportive of those particular needs. In terms of improving health literacy, there's a few different things that we can do. First of all, being attentive and respectful, recognizing as a provider that somebody is not going to come in with the same knowledge that we might think that they do going in, and that's okay. Letting patients know what to expect. What are they looking for from the encounter? What are you hoping to get out of a session? And having patients be explicit about their feelings and questions. Again, creating a sense of comfort and a sense of shared understanding about what the patient's experiences are and how that might impact their access to healthcare. Discrimination and marginalization can, of course, be incredibly challenging issues in the field of healthcare. Denying people care, being less able or willing to give people quality care are significant issues. The CREPT article that we are looking at this week does a great job of laying out some of the ways in which health disparities are experienced and the material impacts that those things can have. For example, one challenge is the idea of heterosexism and heteronormativity, right? The belief that others are involved in heterosexual relationships and the kind of ramifications for LGBTQ plus individuals. One example that was shared in some of my interviews and work was when a queer lesbian patient was going in seeking care. The doctor was asking about their sexual activity. They mentioned they were sexually active. And then the doctor immediately asked a question about what they were doing to prevent pregnancy, to which the patient was very surprised because that was not a concern for her. So one of the challenges of bridging these barriers in care is making sure that both parties understand the types of care that's being needed. We know in the context of HIV/AIDS that there is a lot of care, including preventative care, such as PrEP, that can be used to support people. And a better understanding of that information allows doctors and patients to work together more effectively. In regards to race, what research tells us is the link between health and race is generally more social than biological. When we consider race in the context of other factors, again, things such as socioeconomic status, health literacy, access to information, those tend to be greater determinants of health and lifespan than an inherent genetic element. So some of the differences in ways that this plays out include distrust. If we think back to the Tuskegee syphilis study, there are differences as cultures and races have experienced them with regard to healthcare. Has healthcare been a force for good, or has it been seen as something that non-consensually denies people care, that conducts tests on people without consent, and so on? So there is a very kind of deep-seated legacy of discrimination that might impact somebody's conception of care in the moment. The possibility of risk, being higher risk on the basis of something like socioeconomic status is another consideration. Lack of access to information and knowledge, of course, plays a role as well. One example here, and again, this is something that I noticed from interview research, something that is reported in academic scholarship as well, is that disproportionately, Black and African American patients are assumed to have higher pain tolerance, and as a result, tend to be given less anesthesia and care. So while this is, a myth that on the basis of race, people experience pain and pain tolerance differently, it's nevertheless enacted in a lot of healthcare settings based on that faulty premise. And greater diversity in health leadership can lead to more positive health outcomes because you have a greater variety of perspectives, experiences, and support that allows patients to be seen as it relates to their leadership in healthcare. A lot of my expertise is in regards to disability and its relationship to health. And as we know, people with disabilities or disabled people, they might prefer sequencing or describing themselves under identity or person-first language, so I'll use them interchangeably here. With regard to disability, there's oftentimes a dichotomy, right? Either disability is treated as the thing, the most important thing that a doctor is going to be looking at. For example, this diagnosis of ADHD impacting and coloring the way that a provider seeks care, or it's seen as something that is avoided entirely, right? Where it's not taken seriously as an element for people to think about. In particular, disability can oftentimes be infantilized in healthcare. That is, people with disabilities are treated as if they're children, as if their cognitive ability is lacking, when in many cases, that is not the case at all. And sometimes disability just has nothing to do with the visit. If someone comes in and they are coming in a wheelchair, and they're perhaps not at all seeking any care related to conditions that have them in a wheelchair. And sometimes disability brings with it assumptions about other health issues. That is, because someone has ADHD, there's an assumption from a doctor that they are not able to prepare a healthy meal, which could be entirely inaccurate. So one of the challenges is the assumptions that are brought in about disability. Another thing to think about with disability as well is that people with disabilities oftentimes have more than one disability that is impacting their experience. So assuming that they only have a single disability can be an issue that causes other disabilities who might be relevant to the issue to be ignored. For example, I've talked to interviewees who have been both autistic and have Ehlers-Danlos syndrome, and oftentimes EDS is the issue or topic that they want to address with the doctor, not autism. That's not on the docket. But the doctors oftentimes might choose to talk about autism instead. So the challenges of healthcare and disability are in many ways related to trying to understand and prioritize needs in an affirming way. As it relates to communication with children, what we know is that children oftentimes have a harder ability to speak about their concerns, right? They're feeling pain, but they're not exactly sure how to concretely describe what that experience looks like. So children move through different stages of identity development, of coming to understand and advocate about health. They have a pre-logical stage that treats illness as if it's something outside of them, right? It's this monster that's hurting them. Then there's a move into a concrete logical. It's understanding some of the differences. I feel a cut. That doesn't mean that I'm open, right? Or it's something that is happening to my body. And then a formal logical is understanding the complex issues. I recognize that I got sick because I was, sharing lunch with Jenny, and Jenny was sick, and so now I'm sick, right? So children come to better understand aspects of healthcare over time. There was a film that came out on Netflix a few years ago called I Care a Lot. It was a thriller, kind of an interesting critique of the United States healthcare system, because it talked about sort of the issues of taking on a kind of legal guardianship role If you've been following anything related to the conservatorship of Britney Spears, right, you might be familiar with this topic too, that there's a concern that older patients are put into homes or facilities and someone takes on a caretaker role or a conservator role in a way that is meant to exploit or hurt them. And as we see with regards to age, there's a lot of challenges with healthcare, with assumptions about age and so on. Ageism is discriminating on the basis of age, saying this person is older and therefore they're not going to receive this quality of care. There was a very dangerous point in COVID where we approached a point of discussing rationing care in some states because of the limited hospital beds and availability. And many of the rationales provided about care were using things like age. Age does not necessarily mean cognitive decline, right? There are a lot of people who are older and are incredibly talented, have great cognitive ability, have great experiences and perspective to bring to topics. But older adults oftentimes have more difficulty being heard and being able to communicate about their health needs. They're not taken as seriously on average. Some other issues, right? Sometimes older adults are treated as if they're significantly younger, right? You don't look a day over 30. Sometimes that's used for humor. Sometimes people don't try as hard to help older people's health out of the assumption that that person is older, so it's not as important to provide them care. Treating people as helpless, right, is creating this pattern where somebody comes to believe that they themselves are helpless. And caregivers oftentimes are underestimating the desire for information that older adults might have. Tell me about the surgery that you're doing. Tell me about the medications that you're giving me, right? That information might be really important. So communication accommodation theory is something that's super relevant in talking about this issue, right? We oftentimes, when we communicate about health and related issues, are going to mirror our communication styles, right? We communicate in a way that's similar to the person that we're communicating to. We converge, we make similar kind of nonverbal and verbal elements of our communication, whereas divergence might be communicating in a way that's very different. What this is relevant to is the ways in which we might over or under accommodate our communication. We over accommodate, for example, if you are talking to a person in a wheelchair, that would be doing something like bending over, which a lot of people who use wheelchairs find to be disrespectful because it's like you're talking down to a person rather than just staying standing and then tilting your head downward. But on the other end, under accommodating might be somebody is coming in with a wheelchair and they have to go up a flight of stairs and there is no access to an elevator or ramp anywhere. So accommodating means providing support while also not infantilizing or talking down the people that you're working with. So to improve our experiences of healthcare across social difference, there's a lot of different things that we can do. One of them is not to impose your own worldview or perspective, again, pushing back against the role that ethnocentrism has in the process. Opening up dialogues, allowing people to effectively communicate and engage with each other across difference. Communicating in culturally acceptable ways, understanding the norms and values that one of a culture might have. For example, a collectivist culture is greater focus on community. Listening, right, rather than telling people what to do, as we talked about, a good model of patient-provider communication is the idea that the patient is making a decision, but they're doing so in an informed way from a provider. And empowering people to use the resources and skills that they need effectively. And if we look at culture, right, rules, beliefs, practices, they're not held by an individual, they're held by a group or larger entity. For example, we might hold this in terms of national identity, we might hold this in terms of clubs, activities, groups, membership that we find to be especially important. And our experiences of culture are going to shape how we behave, act, and relate to issues of health. That is, depending upon the cultural experiences and background that we have, our understanding of health and science issues are going to be very different, along with our goals and methods that we have for achieving those goals. One of the biggest dualisms that we might think about here are some of the differences in terms of Eastern versus Western perspectives about care. If we think about this historically, a lot of Eastern perspectives about health and medicine have focused on balance, on rhythms in the body, whereas Western ideas about health tend to draw a bit more from scientific models that frame the body as a space that's prone to outside invaders in a similar way that somebody might invade a country. So this is oftentimes a big difference in how health might be thought about in different ways. A lot of medical professionals and experts are ones who are integrating these types of approaches, recognizing that Eastern and Western approaches alone are not necessarily getting the full picture. There's also what's known as the organic perspective, which determines health on the basis of physical indicators. That is, your health is what we can see. Evidence-based medicine is making scientific studies the focus of how healthcare is provided. And the harmony perspective is the idea that an overall well-being and balance is crucial. You might be familiar with some of the ways in which body and life force are used, including the use of qi as a life force energy to explain the way that we might experience balance in our relationships. Cultural perspectives also play a really big role here, right? The cultural background that somebody has is going to impact the way that they talk about care. Think about how people might attribute supernatural causes. For example, being invaded by an intruder versus saying my body is in distress, right? Cancer is oftentimes very much framed as something that we need to fight. Right? Metaphors of war are commonly used against cancer in order to portray a successful battle that a patient can have in a lot more individualistic and Western cultures. One area that I focus a lot on is the role of stigma. If you have ever read Nathaniel Hawthorne's The Scarlet Letter, the premise of that book is that we have our main character who has committed adultery and has to wear a large letter A on her dress wherever she goes. This is an example of a stigma, right? A symbol that's used to recognize somebody as being rejected, socially outcast, and therefore less deserving of support. So stigma as a social rejection and sort of a disrespecting of the individual comes from a Greek origin. And stigma is a major factor in terms of receiving care and support. If someone is experiencing stigma, they're more likely to be socially isolated. If somebody has a disease or condition that is causing them to be rejected by others, for example, leprosy was commonly seen as a stigmatizing condition. I don't want to catch this, so I'm going to be away from you. But even conditions that don't necessarily have a contagious component. For example, seeing someone with a difference in limbs that they possess or fingers that they possess, right, can be stigmatizing in its right. Saying, what's wrong with you, can commonly be used as a way of stigmatizing an individual. Someone can oftentimes internalize stigma, right? If someone suffers a major injury to their body, such as a burn injury on their face, they come to believe that they're ugly and that people don't love them on the basis of being teased, ridiculed, and mocked by others. Stigma can also lead to a lack of care. People aren't seeking out care, they don't believe that they deserve care, or they don't understand where to begin with care. There's less of a desire to seek out care because of the experience of stigma. Stigma is seen as one of the greatest barriers for healthcare and receiving support. And so understanding the social and cultural factors that go into stigma is crucial if we're trying to bridge those gaps. We can also consider role approaches, right? The idea, the set of expectations that people in a culture might have about their relationships to things such as health. For example, a more mechanical or scientific perspective uses bodies like a machine, right? So we see the machine metaphor being used a lot. Like I say, oh, I'm going to the doctor, I just need a tune-up. That might be an example of using that type of metaphor to describe the body. And under a paternalism role, patients are treated like children and caregivers are like parents. Again, talking about the role of patronizing and being condescending toward parents or toward patients, it's important for us to understand how roles and role shaping might impact that process too. There are examples here of faith healing, right, of Indigenous and Native American populations who have exhibited a variety of healing styles, faith healers who channel and utilize holy power, including the idea of glossolalia, a trance-like state that's associated with healing as it relates to shamans and leaders in indigenous cultures and communities too, recognizing that forms of healing and care take a variety of different forms depending on the context and situation. You might also be familiar with the idea of a placebo. This is oftentimes used in scientific studies in order to determine if a medication is actually effective. So a placebo is usually something like a sugar pill. It's not the actual medication that somebody is being given. It's a substitute, an inactive treatment. And sometimes people aren't told that this is an inactive treatment. This doesn't actually do anything, but they're given it, and the goal is to see if the psychological impact, somebody thinks they're taking this miracle drug that's going to cure their headache, is actually working. They're actually feeling the impact compared to the person who took the actual medication. There's no real difference between the person who took the placebo and the real medication. We can assume the effectiveness of the medication is psychological rather than actually anything in the medication itself. So the placebo is used a lot in scientific studies, but as we discussed in the context of Tuskegee syphilis and other studies, there are ethical concerns about using a placebo in settings in which someone is genuinely seeking care. We also need to consider consumerism, right? People use things like leaving reviews for doctors and physicians. Healthcare in the United States is very much happening under a consumerism lens, reviewing and assessing products. Is this a good doctor? Buying medication and care, right? This kind of language of consumerism is in many ways employed in healthcare settings. When we think about culture as it relates to health and illness, we should think about patients as partners, right? They share goals, they work with us to develop solutions, and it's not a patient's job to direct every single thing that a patient does without their consent. And avoid assigning cultural beliefs or assumptions onto others. Perhaps there's someone for whom seeking radiation or chemotherapy is just not culturally what is respectful of their identity and beliefs. So it's important for us to engage carefully on these issues and think about how to support those considerations. You can also think about the idea of alternative and complementary medicine, right? Things that are not necessarily approved by a formal doctor, but can sometimes be useful. Holistic medicine in particular has gained popularity, the idea that we need to be attending somebody's whole body rather than just attending to particular signs such as physical signs. And while there are some benefits to offering this kind of holistic alternative medicine approach, there are also some risks to consider. For example, there might be health risks associated with a particular treatment. People might be swindled into buying things that don't really work. There's also concerns, particularly if we think about like some of the superfoods that have been advertised, that can be a risk to endangered plants and habitats, and that if this information about using holistic medicine is not shared with doctors, it can lead to complications and cause further health problems if those issues aren't conveyed. So not to say that alternative and complementary medicine are necessarily bad, but that they come with a unique set of risks and considerations that we need to consider as we're engaging in areas of health and science communication. I wanted to highlight a couple passages from the Krebs piece, which I think does a great job of discussing some of the issues of health disparities in greater detail that are especially notable here. More than 886,000 deaths of African Americans could have been prevented from 1991 to 2000 if African American healthcare consumers received the same quality of care as non-Hispanic whites. Meanwhile, African Americans have both highest rates of infant mortality and highest incidence of diabetes of any group. And it was reported that in addition to heart disease and cancer, hypertension, HIV, diabetes, mellitus, and trauma were significantly larger causes of mortality among African Americans. And dealing with the idea that this is not biological, rather that cultural and social factors, the quality of care that's being given, and other factors such as socioeconomic status can quite literally kill. So, bit of a serious note to end on, but it's an important topic to bring into the conversation. We took some time today to talk about some of the ways that culture shapes our conceptions of health and illness, some of the differences in cultural approaches and assumptions about health, and some of the ways that we need to recognize and engage with some of those challenges as we're seeking out and participating in quality care. So next week, we'll talk about health and science communication online. So have a great rest of your week. Best of luck as you're working through the annotated bibliography, and let me know if you have any questions as you're working through that assignment. I will look forward to seeing those, and I will post another video next week. Have a good one.